Let's do chronic brain disorders now. Page 21, 22. There will be a few Alzheimer's questions, which you already did in MedSearch 1. So just a few. So this will compare the three. So there'll be a question wherein it'll ask you basically signs and symptoms of Alzheimer's, Parkinson's, and MS. All right? Because they share one or two. They share similarities. In fact, a certain percentage of Parkinson's patients go on to develop dementia, okay? Particularly Alzheimer's.
Are you going to ask us specifically what the difference?
Yeah, so there'll be a question distinguishing between MS, Parkinson's, and Alzheimer's. So what is Parkinson's? This is a degenerative disorder. So unlike Alzheimer's, wherein that was characterized by neuroleptic plaques, right? That develop in the brain, and then the patient's brain literally shrinks. Loses mass. It shrinks, so the patient's IQ drops, cognition drops, and it has stages. Parkinson's is a chronic condition. This is caused by a degeneration. It's a degenerative disorder, just like Alzheimer's or any dementia. However, this one particularly affects the substantia nigra, which is the spot wherein it produces dopamine. Now, what is dopamine? Dopamine, besides being a neurotransmitter, it's also responsible for not only maintaining blood pressure, but also for controlling muscle movement. So if you remember in myasthenia gravis, we talked about acetylcholine. So this particular neurotransmitter allows us to control muscle movements, meaning for muscle movements to be purposeful, let's say I want to pick up this remote, dopamine is responsible for that. Acetylcholine is responsible for muscle contraction, but to control and regulate those muscle contractions, I need dopamine. So these patients have a decreased amount of dopamine, so allowing them to have the symptoms, which are the muscle rigidity. There are 4 classic features of Parkinson's. The acronym is TRAP, T-R-A-P. So number 1 is tremors. The tremors here, if you observe Michael J. Fox on TV, he has resting tremors. So in MS, when do the tremors appear? When they move, right? So when they move, they have the tremors. This one, Parkinson's, when do the tremors? When they're not moving. So if you notice Michael J. Fox, he never sits still. So when he appears for interviews on TV, he keeps moving. So he figured out that as long as I keep moving, I can prevent the tremors. So he avoids the embarrassing tremors by keeping moving. Okay, so he figured it out. How did Muhammad Ali appear on TV? Muhammad Ali was just like this. Okay, so he figured it. Okay, so I don't have to look like that. So I'll keep moving. I avoid the tremors. So between 30 and there's no limit to the upper range for when you develop it. We don't know what causes it. There is a treatment. You've probably seen it on TV. We have a new drug for not only Alzheimer's, but for Parkinson's as well. But still very expensive, and it's not mainstream yet. So as already mentioned, so there's a problem with dopamine production and storage. The challenge with treating the disorder is the blood-brain barrier. So not many medications can be used because of that limitation. So not all medications can effectively cross the blood-brain barrier. So we are limited with the options here. But if you remember in myasthenia gravis, which was a movement disorder similar to Parkinson's, that one affecting the acetylcholine receptors, right? So the same drugs can also benefit the Parkinson's patient. So you'll see similar drugs used here. However, because the problem is with a deficiency in dopamine, most of the treatment will circle around increasing dopamine, or the patient is given dopamine itself, or we try to stop the destruction of dopamine. So those would be the different sets of medications used here. So same idea as with myasthenia gravis. As already mentioned, the acronym is TRAP. So we have tremors, rigidity, and there are varying degrees of rigidity. So as the disease progresses, the patient goes from cogwheel rigidity to spastic, and then to finally lead pipe, meaning they're very, very rigid. Okay. And the next one is akinesia, either no movement, which is also known as freezing episodes. The patient literally freezes, meaning no movement, or there could be slow movement as well. So either no or slow movement. And then finally, postural instability. The patient has a stooped posture, and then when they walk, they will look like they're about to fall smack on their face, but they typically do not. So there's tremor, rigidity. Again, there's different levels of rigidity. So it can be lead pipe or cogwheel, depending again on the stage, the severity. Brady or akinesia and postural instability. So the propulsive gait we call as shuffling gait. Other descriptions, as already mentioned, is propulsive gait. The other manifestations are related to the cardiovascular effects of the disease, so related to dopamine. As already mentioned, dopamine is responsible not only for movement, but also for cardiovascular function, for vasoconstriction, maintaining blood pressure. So there will be uncontrolled sweating, drooling, which affects the patient's swallowing, causing them to be high risk for dysphagia. Who has taken care of Parkinson's patients? Okay, so what do they look like? Constant tremors, right? Then they hold the food and right, yeah, uncontrolled, right? So they have these plus the blood pressure, the labile blood pressure. They have hypotension. Plus not to mention the medications they use have side effects of hypotension as well. So dysphagia is the most common cause of pneumonia. These patients will aspirate, and then once they aspirate, they get pneumonia, and then they go septic, and then that's usually when these patients eventually die. Okay, so one of those aspiration episodes will bring them to the hospital, and then they never go home. As already mentioned early on, patients eventually develop dementia. Somewhere in between, they will experience psychotic episodes, like they'll have hallucinations, although not all, but most Parkinson's patients. We think that that's why there's a question on comparing this to dementia, because they do share some manifestations to those of Alzheimer's dementia patients. Contrary to what you may believe that these patients are institutionalized, not all patients with Parkinson's live in a long-term care facility. Majority live at home, either alone or with caregivers. No, really, it's more from just continued degeneration of the brain. So the patients, again, the sad thing about this is the patient's body fails. They also have, as far as the facial expression goes, it's gone. They have a face, mask-like face, as you may have noticed with famous celebrities. You've seen Muhammad Ali, for instance. Okay, he had no expression, right? But he's still very smart. I mean, he cracked jokes really with a poker face. If you remember the last few appearances he did have on TV, they have their body fails, but then their mind is still very sharp. So how do we, let's be honest, how do we treat people who act like that? Do we treat them normally like anybody else? I mean, just be honest. We tend to treat them differently, right? Say we start, I mean, unconsciously we kind of talk to them in a funny way, right? Like we talk to them as if they have, you know, a disability, right? So when in fact their mind is really very sharp. So how would you feel if you're treated that way by everybody around you? Even your family members tend to treat you that way. So does it no wonder they develop depression, right? So again, dementia, eventually they have lack of sleep, and the psychotic episodes, again, like visual or auditory hallucinations, they get that. You see things in the mirror, for instance, or hear things. As already mentioned, there's stages here in which will vary in severity. So that means the symptoms will just get worse over time. I mentioned the freezing episodes or phenomenon that they have. This can be brought on both by the disease and also by the medications. What will happen? Let's say you got diagnosed in your 30s or 40s, and this is lifelong. What will happen if you take the same medications for decades? What will happen to the effectiveness? You develop what? Tolerance. Okay, so we consider that with treating with pharmacologic treatment of Parkinson's. So when they develop the tolerance, which means they will have more freezing phenomenons now, or freezing episodes, because the drugs no longer work. So it's time now to switch. So these people will cycle over different drugs. So let's say we start with this list, and then each time we switch because they develop tolerance every few years, and then we go back again to the first one. So that's how it's going to be. Okay, so we'll discuss the treatments shortly. This is something strange. One of the diagnostic tests they do is micrographia, which means they have the patient write something either on a whiteboard or a piece of paper, for instance. The handwriting will go from big to small and then smallest eventually. Okay, so that's what we call micrographia. And it's common in all patients with Parkinson's. They don't do it on purpose. They just they're asked to write a statement or copy a sentence, for instance, and that's how they write it. Okay. So I already mentioned the mask-like expressionless face. So you can't tell, and they have the decreased blinking, so that dries their eyes, so it's not uncommon. They'll be prescribed artificial tears as a result. So another thing that will cause them to be treated differently is because they're slow to respond. You ask them a question, and then it'll take time for them to respond. Sometimes they'll have problems starting the words, and then once they start talking, then it'll appear normal or sound normal, but it takes a while for them to a few seconds, so there's a delayed response, right? It's not because of a mind problem, it's really a motor problem. Okay, so they cannot begin the speech right away. Doesn't mean they're trying to assemble their thought. The thought is there, the body is just not able to respond right away. And over time, again, the patient will develop dysphagia. As I started earlier with, patients will experience aspiration episodes, and then they'll have the pneumonia and sepsis, and eventually die. So here are a list of complications. Now, when they experience the dyskinesia, they can no longer, because dyskinesia is severe impairment of movement. No, this is characterized by severe freezing episodes. When they walk, it's like they have a magnetic gait. Let's say they're standing, right? So they'll like do this, It's like the foot is stuck to the floor, right? They want to move, but they cannot move. Okay, so those are the manifestations as the disease progresses. There's treatment for those just to extend the life. Okay, so again, we cycle through medications. For diagnosis, not easy to diagnose. There's no blood test to diagnose Parkinson's. They resemble other disorders as well. So this is clinically diagnosed along with an MRI just to distinguish, do you have Alzheimer's? They see no neuroleptic plaque, so it's not Alzheimer's, and then they'll check the dopamine levels, then that will help with the diagnosis. And with the writing also, so micrographia is also used to help diagnose. So medications is the mainstay in addition to physical therapy and speech therapy as well, and occupational therapy. So it's purely symptomatic. Start with the medications. The earliest drugs used is levodopa. Levodopa is dopamine. It's converted to dopamine at the brain. The problem is getting it across the blood-brain barrier. Now, it's destroyed though as it crosses the barrier. So therefore, it's never given alone. It's given with carbidopa. So here's the rationale. Carbidopa is added to levodopa to avoid destruction or metabolism of levodopa before it reaches the brain. Make sense? So making dopamine more available as it crosses. So the you've given carbidopa, levodopa, right? Usually 150 milligrams. No, 100, sorry. No, 25 carbidopa and, no, 25, yeah, 25, 100. The brand name is Sinemet. Does that sound familiar? Yeah. Okay, so Sinemet is the most common, cheapest treatment for Parkinson's. Most people are started on this and they benefit for the first year or two. And then again, the tolerance starts. Now it's time to switch again. But we can always come back to Sinemet later. So as already mentioned, benefits begin to wane over time, about 2 years. So we switch to another one. The most debilitating effect of the disease and the medication is the dyskinesia. Again, dyskinesia is the freezing. Okay, the patient has difficulty moving, very slow or no movement at all. They have these jerking, you've discussed tardive dyskinesia in psych meds, in mental health. Okay. So what's the characteristics? It's the uncontrollable jerking, right? So lip smacking, patients will have that, right? They're good. Yeah, you've seen people like that. So that's what we call dyskinesia, okay? It's embarrassing because they cannot control this, okay? So these are all side effects of the medications. So the patient will have on and off. We like to keep them on the off episodes, but when the off episodes, meaning the drugs no longer work, they have dyskinesia, is the most challenging part of the therapy. And here are some other adverse effects of Sinemet or carbidopa, levodopa. We have more medication, standby, surgery. No matter how rich a patient is, none of these surgeries really help, okay, significantly. They can try, but as far as I know, the rich celebrities have not undergone the surgeries because, of course, these are options, but because of statistics, it's not really helping long term. Plus, not to mention the possible complications of the surgery. So most people with Parkinson's do not bother with the surgical options. So they continue with the medications as long as we monitor them. They, fairly relatively live as as best possible quality of life they can have with medications alone. So here are the drugs. It's a drug chart. So what do I test? Nursing responsibilities, which are teaching and managing the side effects. I wish I could tell you which ones. It's all of them.
You could tell us.
Okay, so I did. It's all of them because all are used. So benztropine is the oldest anticholinergic used, but because it's an anticholinergic, can we use it for elderly? Not safe, right? Because it causes the urinary retention, fluid overload, dry mouth, blurred vision. And then, yeah, so it's an anticholinergic, so contraindicated in glaucoma because we don't want any fluid overload or fluid retention. Amantadine, which is also used in some psych medications. It's technically an antiviral, but seems to have anti-Parkinsonian benefits. And then we have bromocriptine, which is, bromocriptine is, forgot the brand name. Anyway, so these are dopamine agonists, increases production of dopamine. Then you have you've seen this in restless leg syndrome, ropinirole. So this is only beneficial for the early. Then we have selegiline, MAOIs. Okay. Then we have COMT. COMT inhibitors are never used alone though. They're usually given with Sinemet to decrease the dyskinesia episodes. So, but entacapone should be covered by Medicare nowadays. So again, the patient cycles through these medications as the years go on. Now, when the patients have severe off episodes, meaning they're really having severe dyskinesias, the patients may have to be put on a drug holiday. Now, drug holidays can be dangerous because drug holidays mean the doctor will take them off of all the medications. Not a single medication will be given just to wean them off. Okay, so when the doctor decides to do this, a drug holiday, typically the patient is institutionalized. If not hospitalized, put in a rehab facility, okay, to undergo drug holiday. So drug holiday can be a couple weeks to a couple months. And then after that, we restart all the medications and it's like the first time they're taking it. So they have good benefit from the drugs again after a drug holiday. But the danger there, that's why they're institutionalized, is what? Because they're not on any medication. So what's the most dangerous? The dysphagia. So these patients may aspirate during that episode. So very important to have 24/7 monitoring. So that's why they are institutionalized during a drug holiday. Skip the surgeries. I'm not testing surgeries. They're not really popular. And with any other patients with decreased mobility, what are your complications besides aspiration and pneumonia? Falls, you've got pressure ulcers, DVTs, okay, bowel. Most of these patients are constipated, and then bowel and bladder problems as well. Okay, and then psychosocial, of course, will be the depression. Falls is because you can't stop them from walking. I mean, they want to walk, and then keep in mind, their intellect is intact. Okay, so don't treat them like they have confusion or dementia. Okay, so we tend to do, no, sit down, and then that will frustrate the patient. Okay, because I'm not stupid. Okay, I don't have dementia. They just act like it. Okay, so they move like it. It's very frustrating. That's not to mention they have no expression. Okay, so when they speak to you, because it's hard, right? When you communicate and then you don't have any special facial expressions, like, how are you feeling? I'm happy. Okay. Doesn't matter whether happy, sad, angry, there's no facial expression. So the more we think, oh, this guy's crazy. Any questions on Parkinson's? If appropriate, the speech language pathologist may eventually recommend tube feedings, okay, to these patients, especially when they're developing um, dementia already, okay, unless the patient has advanced directives.